Well, thank you. And as I said, a family, but I really mean it. This is the start of something. There's a camera there. I think it's a very good initiative. It's a very timely initiative in the history of the European Academy of Childhood Disability. And the idea is to work with generations. And you are the first of these generations. So what I really hope is that the connection between you will live on. Not only live on, but you'll make something out of it. And so maybe you'll find a family name for yourselves, with Pisa, or I don't know, it's up to you. A self-given name. But make sure to really establish a network. Follow up what you do, engage into discussion, meet up at the annual meeting, but also create other occasions. And like in every family, there are also clusters, and then the clusters can make bigger clusters, and so on. So I'm sure there's a seed for something really good through yourselves for the field, for children, and for what is dear to us. You've had a very busy program up to now, and it is still busy. It's going to be busy up until the end. I see you're very attentive, which is a good start for the day. Keep on. Take, but give a lot also. And we're going to make it as interactive as possible. So I think we can use this. So we have a few topics which we're going to articulate with what you've had in the other days, and also tomorrow. One of the topics is, how do we reflect on the ethical issues of what we do? It is not a separate topic. It has been there all along. This is what has brought you here. It is something ethical for you to take your time and be here and reflect. And then about communication, about expressing what you do. We're going to think about scientific publication. How do we translate those research questions? How do we translate experiences into something that can be used in the wider community? I said you forming a family, and this family is talking with a wider world and a wider community, not only within the EACD, but much wider in the world. So we're going to find good avenues about how we think about this. So we start with ethics. Now, have you received the message of thinking about ethical questions in your practice? Yes, you have received that message. That's good. Okay. So, as a means of introduction, I'm going to show just a few slides, and then you'll receive all those slides. This one, you think? Yeah. So this is a book that we put together with clinicians. The way we did it a few years ago was we thought just along the lines that I just described, thinking, well, ethics is for us, is something we do in everything we do. Ethics is not just about the big topics of society. It's not just about end-of-life issues, which are also ethical and very important. But in every practice, there are ethical questions. Many of them, we don't need to address them, because we're so confident with our values that we don't really see a dilemma. But as soon as we feel uncomfortable, we need to name why we're uncomfortable and address this. So what we did is we asked clinicians through academies, the the EACD, but also our American sister academy, the AACPDM, we asked the members, what are your ethical dilemmas? What do you have to deal with? Describe a number of topics and perhaps situations, and then would you be willing to go further and provide us with a story and a reflection about it? And so this story began, and so we received loads of them, so we discussed with the potential authors, all clinicians, and like here, a reflection of the variability in the field. So you see that many aspects are being covered here, not only in terms of discipline, but also in terms of perspective, in terms of setting where we work, and also in terms of culture. And we did a very active editing work. So these friends and I, including an ethicist, clinicians, and also a mother of a child who had a severe disabling disorder and passed away, and then she studied ethics. The mother was not there to represent parents, but to provide, within the multidisciplinarity, to provide us with a perspective which we felt that we didn't have, and we learned a lot. It was a very tough experience for us to see how we dealt with what we believed to be our certainties, how patronizing we could be when trying to show empathy and try to think how people might think, and then realize that we may be really biased. And this is the result, this book. And in the book, we do the exercise that we're going to do together now. Now, why do we need to talk about it? We need to talk about it because the world is changing. You've heard a lot about functioning, about this new emphasis on how people function as opposed to just what they are or what they lack. And this goes together with new ways of asking questions. I say ethics is in everything, but conscious ethical questions are not necessary for every issue. When they do, it is an opening to something different, very different from the rest of our practice. And so we have a few guidelines that we can follow. In the book, we based the reasoning on principles. We did not invent those principles. These principles were suggested by people in the wider field of bioethics, and they work really well for the field of childhood disability. These principles are the number of 4. One is respect for autonomy. Another one is the only one I was taught back then when I was taught about ethics at the university. It was do not harm. But then there's another principle next to it. It is do good. It's not the same. And the last one that we must not overlook, and which is in a dimension which appears to be further from all these personal principles, is the principle of justice. So let's look at what they mean. But before doing that, let's realize that there's no hierarchy. We don't say we start with respect for autonomy and then we go to do no harm and so on, and the final one will be justice. No. The other thing is we need to know it in advance. They are not going to provide us with answers, but with frameworks in which we can reorganize the questions. You may think of ethics as doing good. Yes, you may think along those lines, but when you apply it, you realize that it's not about good or bad, what is good, what is bad. And mostly these principles serve as a framework to engage into dialogue. And out of this dialogue, attitudes will emerge. Ethics is not just about decision-making. Ethics is wider than that, but sometimes it is about decision-making. Not what is the good decision, but which decision can we share, we can move together with it. And it doesn't mean that we have to agree. It doesn't mean that we have to harmonize the different realities, mine and that of my colleague and that of the other colleague from another discipline and that of the mother and that of the father and that of the child and that of the grandmother and so on. At the end of the process, of this step of the process, maybe everyone remain with their own realities, but we created a possibility for dialogue, which is constructive, with much humility. So the first principle, respect for autonomy. And that is the right to make your own choices. This has been relatively recent in health, in medicine. So we are still moving away ever so slowly from a model where the health professional was a sort of mediator between reality and some transcendental knowledge. And as they act as this mediator, the health professional had supreme knowledge. And so knew better what the better choices are. We're moving away from that, realizing that it is simply wrong, that we're not taking into account what really matters. When we want to help, if we can help, and this is the role of the health professional, it needs to be meaningful, and the meaning does not come from the health professional. The meaning comes from the experience of the person, whether we like it or not. And sometimes it's really hard to keep the dialogue open, but this is what we need to do through this principle of respect for autonomy. You know the phrase informed consent. We use it, and it has been formalized, it has been legalized. Sometimes it's a document that one must sign. When we say informed consent, it means information, giving appropriate information so that people can really be actors and not just follow. And the information needs to be appropriate. It's not a matter of giving a book, of saying, well, read on this website or that website, or talking in your jargony language and following your very complex and professional reasonings. This means that the person doing the choices must be competent. So this is also a legal issue, but between us, it isn't. Between us, it's recognition, first of all, that the person will be competent, but then we have specific questions in our field with children, or perhaps with very young children who can't express themselves, who can't engage to a level of dialogue where the complexity is, or children with impaired consciousness, children with impaired cognitive abilities. And very often in our field, there is a surrogate, that is, somebody else takes over the competence of the child and represents the child's interest. You may have noted that the child's interest is not one of the principles. Why? Because the child's interest is a standard. It's not something that can be objectively discussed. It is subjective. And when you ask, 4 different people in the room, 10 different people in the room, just 2 different people in the room, they may have different notions of what the best interest might be. And the discussion will be easier if we talk within a firm framework like that of competence, like that of autonomy. Now, very often in our field, it is the parents. We say the parents as though it was simple. Now, the parents, is it the mum or the dad? What if they don't agree? What if we feel that they are not the best advocates for their child's interest? Well, these are ethical questions. So we need to keep them in mind, and maybe they will come back in your case presentations. Second principle, beneficence. Do good. Well, that includes preventive interventions. Patient's interest is quite central in here. So this is what we have in mind. And when we say do good, we mean do more good than harm. Because in real life, situations are not just binary, and it's either good or it is bad. The other principle, which seems to be symmetrical to the previous one, is non-maleficence. Do no harm. You need to realize that it is very often met if you want to do nothing. I'm not saying that that is the thing to do, but we need to realize that when we suggest, well, no intervention, perhaps that's what we have in mind. But then we need to measure that against the last line. We do not want to do more harm than good. Quality of life, you also notice that it is not within this, and you may have noticed that it is not under the ICF. You've heard a lot about the ICF. Quality of life is not there. Do you want to say why it isn't? Why isn't quality of life in the ICF? Who wants to test the microphone? Veronica.
I think it is inside.
You think it is?
But in the
right?
whole picture. Like if you have this solved, like until participation, personal factors, environmental factors, quality of life is there, I think.
Okay, so you think that that's the framework that perhaps was the idea of the people at the World Health Organization when they suggested this framework, to say, well, we don't need to pinpoint it because it's not a point, it's when you have all this. Other visions here. I see Arnab, yeah. I saw you twitch.
Quality of life is very subjective. What I perceive of my quality of life may be very different to what you perceive or that person perceives. It is very individual. So on the same levels of functioning and participation, a person might have a poor quality of life, another person might have an excellent quality of life. Nothing else might change in there.
Because it is so subjective, right? Do we need it in the ICF? Should it be added? Does anyone think? So Arnab is offering a slightly different vision to yours, because you are hoping that when we meet all that, we get quality of life. And perhaps very often we do, but Arnab warns us that it might not always work that way. The values, the personal values which underlie quality of life might not be there, nicely described within, say, participation. For some people, and we need to know that. Would we need to add quality of life in another version, Costanza?
Well, actually, I think the quality of life should be within the goal setting of us and the patient together. But, well, the ICF is more on intervention, so maybe it can be implicit in the goal setting. I mean, we are meaningful by improving the quality of life. going towards a goal.
Right, so saying that the way you want to use the ICF is for intervention, even though the primary use is really to describe a situation, but you say it's going to be useful to define objective, and you say alongside those objectives, I would like to have a specific objectives for quality of life. Any other thoughts about it?
I think quality of life includes a lot of life aspects, like it's not only about activity and participation and function, but it is also about the freedom of life. It is also about safety. It is also about wealth, and those things, they depend on the situation in the country. For example, the freedom might depend on the political situation of the country. So for one to improve the quality of life, these things may matter for one more than the health, and so it would be difficult to include it in the ICF. Maybe it's good to consider it.
Yes, I tend to agree with you. I think that it's really something different that is very important. When we talked about the best interest, we're much closer to quality of life issues than all the operational aspects. How will we assess quality of life? Are we the good judges? So if I ask the question, you say, no, of course we're not the good judges. Well, we are to some extent. Who's the best judge for their quality of lives? The child, the person themselves. It is subjective. But then we said that often we ask parents to play a role. How does quality of life as assessed by children compare with quality of life as assessed by parents?
I think that might depend a lot on both on age and also of if the parent have a similar way of thinking as the child.
Similar way to the child's way of thinking.
Yeah, if they sort of think the same things is important.
Yeah, I agree that is the key thing. I mean, you can try and identify other factors. You said age, you said a country setting, level of service, and so on. But it is so subjective, it is so personal, that you can't just say, well, it is the same. What the child perceives as quality of life is the same as what the parents. And I'm saying that not as ideology, because this is what the literature has very clearly demonstrated based on how we use it, and it's a number of tools, of scales.
It's subjective, definitely, but it's also limited by your own experiences in terms of, if you take a really non-important example, if I'm eating an ice cream, I might be like, oh, this is the best ice cream ever, without realizing that there's a better ice cream shop down the road. Mm-hmm. Does that make sense?
It does. It does, especially in Italy. And I'm still inclined to remain with my fascination for the fact that it is subjective. And who am I to say that, well, that is not the best quality of life, because if you walk a few more yards and you get a better ice cream, that would be better quality of life. It's all about experience. What is experience? Not very easy to define, but at least it can be described in terms of quality of life. And when you were having that first ice cream, you were at the top. And perhaps you'll be, for other reasons, so far as your own very top, based on your possibilities. Okay, so this was just a way of showing that we need to think very widely. And now justice. Justice is something we tend to overlook in practice, because we were taught about the importance of the singular relationship that we are to build with the person and the family and perhaps a wider setting, but with the center being that individual person. Now, justice is not about that specific person. It's about a fair distribution of service. Service, in this case, is you. You're a PT, you're a psychologist, you're a medical doctor. You're a service. You're there to serve, and as you, in your role of servant, you're not supposed to serve only one person, but there should be a fair distribution. So this is a principle that is at the systems level. So if the child wants therapy for 6 hours a day, every day, you may think of it in terms of, well, is it useful? What Costanza said, what is the goal? How do we plan intervention and so on? But even if you think that the more is the better, we hear this slogan now, there is an ethical question here. Can you devote 6 hours of your day every day to treat that individual patient? I say these are questions, they're not answers. So, it is part of good practice, it is based on respect and also trust. However good we think we are, we need to trust people and think they're very good and they're actually best. It is a tension between the sameness and differences. Very often you will want to use other situations and say, well, it's the same, but is it different or not? It is all about empathy, so that experience, but it is a very difficult exercise. And humility. And like the rest of our clinical practice, it is based on the rigorous observation of signs, of facts, of data, in a context where you're never going to know all. But still, you need to make practical judgments on situations. So, this was the last slide, and as I said, you will receive all those slides. Who would like to suggest a story, a clinical story, a problem you've had? You've all thought about this. And this problem, so we're going to hear a few now, perhaps 3. Choose one and then work together on them. Who has had a question? Who had a question in practice, in clinical practice, about a child, about a situation? Yes, go on.
Yeah, I've thought of several, but I can share one that I had a patient. He was, or actually I didn't have a patient. I had parents of a patient, and he was, I guess, 16 or 17. He was quite old. He didn't go to school, and because in Sweden we don't have a law saying you need to go to school when you're finished ground school. So he was free to choose not to go to school. And he didn't go to school, and actually he came in once and made it very clear he didn't want to have anything to do with us because he didn't think he had a problem.
Right.
But the parents definitely had a problem in the family, in making anything work. He was very, like, he just had one interest, and he was very, very keen on pursuing that interest. He wasn't going out, he wasn't eating that much, but it wasn't to the extent where you should say that, like, no, he can't decide for himself. And I was very troublesome, but in the end I got him to agree that I could work with the parents, even though he didn't want to have anything to do with us. But that was a long process of having him to agree with that, and I felt like I was sort of pushing his autonomy, but at the same time I had the parents' autonomy because they needed my help. So this was like an ethical issue of what am I, who is my patient, and what am I supposed to do?
These are very common issues. They're no easy issues. I like how you started. I remember when I thought that 16, 17 was really old, but I got over that. So that's one. Let's hear two more stories. Yes.
So I think everybody agrees that the most serious ethical issue in the field of child neurology and, let's say, cerebral palsy is when parents come to you and ask whether my kid will start walking having GMFCS level 4 or 5. And this ethical part is answering. If you say no, parents are really unsatisfied. If you say yes, often you are lying. So this is an ethical part which is not solved till now. And what are your opinions and expectations about answering patients? If you just show them like GMFM curves, you don't answer their question. You're killing their hopes.
Yeah, this is also something that is very common, that has much to do with where we see ourselves in the picture. And of course, we have to be where we are in the picture. And we can certainly pose it in terms of an ethical question. And we'll see how we can do that. A third story, and a fourth.
Yeah, I have a story about treatment for children with CP. And in Sweden, we quite often use serial casting as a treatment for contractures and when they have a low range of motion. Oh, sorry. But we often find that this treatment is quite painful for the children, and we are trying to get at much range of motion that we can get, and then we get them a casting that they will have for several weeks. And not all of these children can speak for themselves, and they used to get some wounds. Is it that? Yeah, wounds. Yeah, so I don't know. Is it ethical to use a treatment because we use it to avoid other treatments like operations, but it's still sometimes a very painful treatment for the children.
Yeah, and this is why ethical thinking should not be separate from clinical thinking, because if we just do the clinical thinking on the one hand and the ethical thinking on the other hand, it will be difficult to reconcile them. But we're going to see how we can address them. So far, so good. Not impossible at all.
My question is, what do you do in a situation where the parents don't want a medical treatment for their child? Because we have that in our setup, but the child should receive the medical treatment to save his life. So we always face
and this is actually not very far from the second story we've heard. We're going to see how we can do that. I could remember up to 4, but we can have a 5th one. That's fine, if you're there to remember together with me.
Well, I actually had the opposite thing that you're talking about. So I had a patient with severe CP, 18 years old, with severe scoliosis and denutrition, in pain, constantly in pain. And the parents wanted to, we were talking about starting gastrostomy to fit him up, and eventually had surgical approaches. And so actually it was really hard to set the clinical decision, and because actually we didn't know what was the best for the patient, and the family was sort of depending on our expert opinion, and we didn't agree within the team. So Yeah.
Okay, so we have a number of stories, and I appreciate that that's just where you are, where again we need to define where we are. Where we are, I described us in an idealized version as mediators who have some knowledge, and those difficulties in articulating them with real life and then communicating. Yes, and so I think that a few of these stories, we can handle them together. One or two more? Yes?
My question is about a situation in which infant and baby make a good treatment, okay, a good treatment with you, but the parents want to make, for example, surgical treatment or other treatment that aren't supported by evidence-based information. For example, surgical situation in which I don't know, or medical pharmacological treatment that aren't
Stem cell therapy,
yes.
and the like. Okay.
Okay.
Yeah. Again, this is how we can communicate in this world where it is not just as it was before. The doctor knew and you're going to do what the doctor says. Not all that difficult, but very important. Yes?
Issue in my practice was the absence of consensus between parents, because a father has a good willing to participate for his child to participate in the study, and mother didn't want the child to do it. So it was really issue to persuade them, because they have some argument because of it, and hadn't some consensus of participation of their child in the study.
Okay. Okay. We'll take that one on board.
But I just want to explain that in Ukraine, both parents are legal representatives of their child, so they both can make a decision.
And that's also an issue. What do we do with the legal system? Is ethics the same as the legal system? And I can tell you, no, it is not. It does not devoid us from our own responsibility. And then we also have a responsibility as citizens, and we can address this perhaps in more extreme examples. But when I said informed consent has a legal meaning, competence has a legal meaning. I remember during one of those exercises, someone said, well, it's very easy. The child is not 18, the child is underage, and therefore should not be listened to. I don't think it's not quite like that, and we can see how we can open to that, but sometimes it's even closer to a transgression. Does someone have a story about justice? Yes.
So, in the UK, a lot of children that have disabilities are given something called an education, health and social care plan, and that's a legal document that a multidisciplinary team has made, and often that outlines the number of hours of one-to-one therapy a child has to receive. And in the UK, we're moving more towards a tiered-based model of occupational therapy, where at the bottom you have a universal provision where an OT is working with the teacher and implementing strategies that support everyone. And then the next level is small groups, and then the top level is one-to-one. And the idea is that a child would move fluidly through this model, but everybody would need less one-to-one because they're getting a lot of their needs met at that universal level. However, parents are sometimes in some schools not happy, and I'm on a a forum in the UK for school-based OT, and we're getting a lot of people saying they're in this difficult situation where this legal document is saying they need to give 7-8 hours of one-to-one therapy to so many children in the school that they aren't able to provide a universal provision, and when they try to do that, they have these difficult conversations with the parents where the parents are saying, I'm happy for the universal provision to happen, but I also want my 8 hours of one-to-one therapy.
Yes, and well, it's moving very slowly, but Spinraza, the treatment, well, even in the UK, you don't receive it equally, and people would want to move or not. So, yes, there are these questions also that have to do with our role in society and how do we deal with the wider system. But there are other questions like, I don't know, the manager of the institution asks you to see that patient because she's the daughter of her friend. What do you do? That has to do with justice. Yes?
Yes. Now, in my experience, I had a problem with the ethic in my current project about the epigenetic outcome in child with abuse and neglect. And we're looking for to study the trauma, but we can't ask to child to remember their experience. This is a very problem for our ethic question.
Yes, and this is about research, and that's really good because I wanted you to start thinking about ethical issues with research and publication. We'll do that later, but I wanted you to think about it because it is not just the same framework. There are other issues too. This is one issue, but we can see how where it fits within this framework. But there are other issues like what we call salami slicing publication. We'll talk about that.
I don't know if this is a justice issue, but it's one that I think a lot of us face, and it's like, at least in Sweden, we have this, like, if you have a diagnosis, a support system will kick in, and you will get a lot more than if you don't have a diagnosis. And then we have a lot of people coming and asking for a diagnosis because they
say
need...
it is autism, it is CP, and then I can get therapy.
And they need this. And you as a clinician have this sort of gray zone.
It is just, it has to do with justice, and it has to do with something else, another value that we'll discuss. Now, just before, go on.
According to justice and fair distribution, for example, in Albania there is a center where children can be provided with wheelchairs and orthotics and prosthetic. And an ethical question that happens sometimes is if a child that is the first in the list can take this wheelchair or be provided with this equipment, or a child that has an emergency and needs it before this child that is in the list.
Yeah, it has to do with justice. What does it mean, fair distribution? Just one more story, not about justice, about an extreme situation. Because here we've heard a lot about daily practice, but more extreme situations.
I had a patient who is 4 years old and was diagnosed to have leukemia. And so the pediatric oncologist, he decided to start the chemotherapy. But then the parents were so religious, and the father refused to start the chemotherapy, and he opted to pray for the child. And for a week, we were begging the father that he allow us to start the treatment, because we were having hope that the child would improve if we started the treatment by then. And the white cell count was increasing so much, and he denied the child of any medication, and we couldn't discard them out of the hospital, so we just let him to stay there, and we just showed him other children who have started the medication and improved. But the father insisted, and he was praying for him, and we lost the child by the end of the week.
Yeah, this is a more extreme situation. For some of us, it is daily practice, but fortunately not for every one of us. But let's say that the child, the decision had been, well, the parents are not the right advocate for the child. We're going to take the decision of doing this. We need to reflect, and we're going to do that, about the fact that a decision is not just a decision for here and now. So ethical thinking is also a projection into the future. Even though we're going to see that we don't need to solve the complexity at once. We can go step by step, but never thinking that when we completed a step, that's it.